Welcome to the Essential Substance Abuse Skills webinar series. I'm Kate Trams, and today we have invited Bob Rarrett to speak on professional and ethical responsibilities. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center, or ATTC. We are one of 4 national focus centers serving the ATTC network shown on this slide. The network also includes 10 regional centers and a network coordinating office. To learn more, please visit our website. This series is designed to be a broad overview to assist in preparing for written alcohol and drugs certification examinations, to enhance existing knowledge, and to improve overall competence and treatment outcomes. Please be aware that this series is not meant to stand alone, and previous education and training is necessary in order to pass alcohol and drugs certification exams. We recommend that if you are preparing for an exam, that you seek additional preparatory help and let this course be one of the many tools you use to prepare. Our next webinar in this series is scheduled for Wednesday, November 19, when Dr. Peter Nathan will present Clinical Evaluation Screening. We also offer the American Indian and Alaska Native Behavioral Health webinar series, and will welcome Dr. Suzanne Carroll Duffy on November 19th to present Creative Therapy for Traumatized Children, the Moving Stories Play Therapy Method. For more information on our webinar series, you can contact me at the email address or phone number provided on this slide. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEHs for a $15 fee. The CEH request form is available for download in the Files pod in the webinar screen, and I will also be sending this form in a follow-up email to all who attended. Immediately following today's webinar, you will be redirected to our GPRA evaluation. GPRA stands for the Government Performance and Results Act, and SAMHSA asks us to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. The survey asks about your satisfaction with the event and will take less than 10 minutes to complete. We thank you in advance for helping us to improve our programs. If you've never used the Adobe Connect system before, you may view the presentation in full screen mode by clicking on the full screen button at the top right corner of the presentation pod, which looks like 4 arrows pointing forward. To return to the regular view, click on the button again. You will be muted for the duration of this webinar. Please use the Q&A pod to share your questions and comments, and we will address questions at appropriate points during the presentation. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEHs received. Today's speaker is Bob Rarrett. Bob has worked in the field of addictions treatment for 20 years. He has been internationally certified through ICNRC and is currently employed by the Ramsey County Human Services as director of a 50-bed medically monitored detoxification program in St. Paul, Minnesota. Bob has experience as a clinician, clinical supervisor, senior manager, director, and executive director in a variety of settings. Bob, thank you so much for joining us, and I'll pass things over to you at this time.
Okay. Again, thank you everybody for joining us today to talk a little bit about ethics and professional responsibility. I'm going to assume that most of you or all of you have had some sort of ethical training, whether it's around a licensing code of ethics or agency has promoted a code of ethics, but I don't think that'll be anything new to most of you. Where it gets interesting sometimes is when we start to talk about some legal requirements for privacy that can conflict with ethical decision making. It gets a little tricky, but we'll talk about that in a little bit. So in talking of vocabulary, again, I don't think these things are going to be a surprise to anyone, but morals, principles, ethical values, and scope of practice, meaning the scope of your expertise. Effective treatment, of course, is person-centered. It's longitudinal for the duration of the illness or the need. Effective treatment attends to the multiple needs of the individual. Should involve multidimensional assessment tools, something like ASAM, or a assessment tool that takes into consideration the different dimensions of a person's life, and again, remaining in treatment for the adequate period of time. A movement in this field, finally, is toward a disease model, chronic disease model of care, which promotes, like I said, longitudinal or long-term care with varying intensities based on the person's need. It's important to understand theory, certainly. Behavior theories are changing, or I should say evolving. It would be helpful, I think, if you've been in the field a while, to revisit some of the more current behavioral health theories, things like the health model, the ecological model. There's some very interesting therapeutic models that have sort of grown out of those original paradigms. You still want to understand the various therapeutic aspects of each model, but they're oftentimes blended, and it's very difficult to say, I use this particular approach. Oftentimes there's crossover. Medication-assisted treatment, I think, will be an upcoming important factor for just about every treatment program to consider. Just like any other illness, addictions requires medication to stabilize folks, to assist with craving, to reduce the effects of the drug take and things like that. Suboxone, naltrexone, Vivitrol, things of that nature. I think the future is going to involve those kinds of approaches more in a more integrated fashion with most addiction treatment programs. Coexisting disorders are very common, of course, as you probably know in this field. Co-occurring disorders should be treated together. That is, the addiction, the mental health condition, the physical condition that might require treatment. Those things should all be considered as sort of a package, if you will, and not treated independently. The slide here says medical detox is only the first stage of treatment. Really, detox can be a service that could be provided at anywhere along the continuum of care. In other words, if someone were doing quite well for a number of years and relapsed and had severe withdrawal symptoms, a detox center might be the open door to rejoining the healthcare system. So detox centers and all other levels of care should be used as needed and not seen as a linear kind of treatment approach. I think people vacillate between doing well and not doing so well, just as they do in other kinds of behavior change. So I would kind of change that sentence a little bit to just say that medical detox is certainly a necessary thing for many people that require treatment for addictions. And treatment does not have to be voluntary to be effective. Coerced treatment can be effective. I think I'm going by memory here, but I think there were certain studies that actually showed coerced treatment sometimes more effective, just because there was more leverage to the person involved. I just want to say along the way here, if you have any questions or if I'm not being clear about something, just type a comment to that effect and I'll try and explain better the point that I am trying to make here. So possible drug use during treatment must be monitored continuously. It also shouldn't be a reason to discharge someone. You wouldn't want to discharge someone for showing the very symptoms that they're there to be treated for. Somebody were diabetic and they went to the doctor and the doctor said, well, you're not following your diet, so I'm not going to treat you. That wouldn't make any sense to us. So the same thing should apply to addictions treatment. If people show symptoms of that addiction, such as using a drug or drinking, it's an opportunity there to re-engage them, maybe at a more intensive level, but certainly not discharge them. Again, long-term process for many people. I don't want to say for everybody, but certainly for many people, it's an ongoing healthcare issue. So we'll talk a little bit about vocabulary, very little, and professional and ethical responsibilities. values, morals, and perspectives, and the distinction between legal and ethical dilemmas. I think, again, there's very little distinction sometimes. I think the two things butt up against each other, and it creates some, as I said, some very unique situations that you have to work through as a clinician. Scope of practice, I won't go into a great deal of detail about this. I think most of you are pretty familiar probably with the kinds of things that typically an addiction counselor is asked to do, the kinds of areas or the types of areas where the addiction counselor is more specialized and trained. All of us, regardless of our education and position, would not want to operate outside that scope of expertise. We'd want to consult with someone who did have that expertise or that or the credentials to adequately diagnose something. All right. This gives the definition of what a legal dilemma might involve and what ethical dilemmas might involve. I think what I'd like to do here is just pose a scenario for you all, and you can just type your response. Kate and I will monitor those. But I wanted to pose this scenario to see how people would respond to it. This is a fairly common event if you work in an addiction treatment or co-occurring treatment program. But oftentimes I found that people weren't as familiar with some of the things I'm going to talk about. So I really think this is important, and I want to pose this scenario for you. So tell me how you would answer this. Say you're a clinician or working in a substance abuse treatment program that does receive some federal funding, and you're the only person available. You're the only professional available at the time. Everyone else is either gone or tied up at the moment. And 5 officers from the Violent Crimes Division, wherever you live, walk into your facility and they say, we're here, we need access to this person, to John Doe. We need access to him because he's wanted for questioning in a murder case. We need to talk to him right now. We know he's here, and you need to give us access to him. I want you to tell me how you would respond to those officers in that moment. And then we'll come back to that in a little while.
Yeah, so if please take a moment and type your response into the Q&A pod. The type where to type is in the bottom of that pod, and if you are viewing the presentation in full screen, you'll need to click out of that in order to be able to see the Q&A pod. And then as we see some responses to that question, I will try to respond so that everyone can see the responses that come in.
Thanks, Kate. Thanks. A duty to warn involves a very specific threat. If somebody came into your facility and they said, when I get out of here, I'm gonna blow up Minneapolis, the likelihood that they're going to blow up Minneapolis is pretty small. So who would you warn in that case, and would the warning even be necessary? A duty to warn implies that there's a specific threat to a specific person or group of individuals or some target of some kind, where you believe that that person actually has the means and intends to harm someone. In that case, you would have an ethical, I think, responsibility to contact that person and warn them. I just would caution, you don't want to, every time somebody makes a threat, feel as though you have to warn somebody. Sometimes the person either doesn't have the means to do anything, or the threat itself is beyond something that you would reasonably suspect that person could do. I'm not an attorney, so I don't want to pretend that I know the answers to that in detail, but in my experience, that's how I've treated that issue. So if you have different thoughts about that, please do let me know.
Bob, did you want to comment on, we've got quite a bit of response. Did you want to take some time to comment on those for a moment?
I'm going to wait for a little bit, if that's
Okay.
okay. Um,
Sounds good.
I have a plan in my head, believe it or not. So we'll come back to it in just a minute.
Great, thanks.
So I just want to continue here, and I didn't mean that to be a distraction for you. I do want to focus on these slides, but I wanted you to think about that scenario while we talk. So ethical values are generally be good, do good, and above all, do no harm. Keep the client alive. If you keep the client alive, you're doing something right. And try not to do harm. Those are pretty, I think, self-evident kinds of values. So adhere to established professional codes of ethics that could depend on your licensing, your state, your profession. But most codes of ethics are very similar. I think where they vary sometimes is in, say, ethical guidelines for having a relationship with a former client. Sometimes guidelines will say 2 years. Sometimes guidelines will say never have a relationship with a former client. So there are variations, but I think in general, most codes of ethics take into account the same kinds of things. You have to adhere to federal and state laws and agency regulations, and you have to interpret and apply information. Ethics is you could spend all day, of course, coming up with various kinds of ethical dilemmas and puzzling through them. That's just the nature of it, and that should be the case. We should always have those kinds of dilemmas. It helps us learn and advance in the field. These are professional and ethical responsibilities, but recognize the importance of individual differences. Again, person-centered care, personalized care, and the conduct self-evaluations piece means really try and monitor your own perceptions, your own biases, and manage your own behavior in relation to the client that you're working with. If you have a particular liking, if you like a client, well, they're just somebody that you just really get along with. You have to monitor whether or not you're treating that person differently than the client that you really don't care for all that much, who may be a nasty person in general. But you still have to provide that same level of care to them as you would the person that you perceive as being friendly and likable. It's a difficult thing to do, but ethically you need to. Always continue professional education. As a field, we have a responsibility to stay current on the science and the most current theories around what's effective in addiction treatment. If we don't do that, which this field has not done well, if we don't do that going forward, we're going to fall further behind the rest of healthcare, and the integration of addictions treatment into the rest of healthcare will become more and more difficult. It's our responsibility as professionals to stay on top of this stuff, whether it's going to SAMHSA's website, whether it's visiting the National Registry of Evidence-Based Programs and Practices, whatever your information source is, we really need to be better at that. I think the whole field needs to really pay attention to current theory, current science and addiction treatment. Use your supervisors. If you have a supervisor, which I hope you do, certainly run dilemmas by them, run cases by them that are complicated and confusing. It's a wonderful way to learn how to do your work better. And of course, take care of yourself in the process. So here's NADAC is one source of code of ethics. The link is provided here. I don't know if the hyperlink works, but there's, of course, there's social work, there's psychology. So you have a variety of different ethical codes to follow. Again, I'm not going to spend a lot on this. I think we sort of covered it. I will focus a little more on confidentiality. Competence is covered under what I was talking about, staying current with the field and being active with clinical supervision. I've really, as I've gotten older, and I've seen the field begin to age, that is the workforce begin to age, I've really felt a strong responsibility to students, employees that I supervise, to really build that next generation of leaders or professionals. I think it requires us to take that extra step sometimes to reach out and really make sure that our employees, our workforce, is well trained and provided with the opportunities that would help them advance if that's what they're interested in. It goes along with responsibility to the profession to keep the profession really legitimate. You know, we're a healthcare specialty, but we need to be just as current on things as any other healthcare provider should be. All right, I'm going to move on to the next slide. Agency ethics this first thing has to do with personal disclosure, and a lot of programs make it okay for clinicians to reveal whether or not they're in recovery. Other programs have decided that's not a good idea. It tends to, in their opinion, it tends to split staff a lot of times. And if someone's not in recovery, obviously they're treated or perceived differently by the clients. I think in my experience, what I found along those lines is that not revealing if you're in recovery is a more effective approach. I think people who are not in recovery in the field have a very useful purpose in that they're objective oftentimes. They're not biased by their own experience, and they can really be an effective balance to recovering people who have that personal experience to offer. So both have, that is, recovering and people who aren't in recovery have things they can offer. Both have strengths, but I think it's better to not allow the clients the opportunity to discern which person would be more helpful. Oftentimes, in fact, if you give clients if you ask them, who do you think's in recovery amongst our counseling staff, they'll usually guess wrong. Mandatory reporting that can generally applies to child abuse or elder abuse. Acceptable practice as a case example. It's often hard for professionals, if I with for a long time, does something that violates an ethical standard. Again, this comes back to your responsibility to not just your organization, but to the mission. We have to police ourselves to some extent. And the more we do that, the more we hold people accountable in this profession, the better the profession will be. So as difficult as that can be sometimes, know who you would provide or provide a complaint to in the event of an ethical violation. We never want to discriminate against anyone. That goes beyond race and culture, ethnicity. It goes down really to, again, to people that are compliant versus people that are not compliant. Oftentimes the people that are not compliant are the people that need our help the most. But certainly we don't want to discriminate on race or gender or any of those variables. Confidentiality is something I'll talk about, I promise, in just a second. Responsibility and competence go back to things we've already talked about. And informed consent means that when a client comes to you for services, you provide them with all available options to them, not just the options that your organization provides. So if you work in a treatment program that does not do methadone maintenance, and you're working with someone with an opioid addiction. Informed consent means that you would tell them there are programs for methadone maintenance if that's something you're interested in. It doesn't mean you're promoting it or discounting it. It just means you're making the client aware of all their options, even if you don't provide those services. It's a very important thing. I think we forget to do it sometimes because we tend to come from the perspective of what we do, whatever the organization is that you work in. This is what we offer, but we need to be comprehensive in terms of offering options to people. Do not discriminate, avoid personal issues, and be knowledgeable about disabling conditions. Okay, this is where we'll talk a little bit about the scenario that I posed. I'm going to give you the right answer, and I haven't had time because I've been talking and reading slides to read all of your responses, but I've been kind of scanning them. And I think most of you have the right idea. This is a very important topic because if you have law enforcement, I'm picking on law enforcement right now because typically providers or clinicians are more intimidated by law enforcement who demand information from clients. But this really applies to anyone. The privacy law that applies to any addiction treatment provider who receives any federal money to provide those services is 42 CFR Part 2. CFR stands for Code of Federal Regulations. 42 CFR Part 2. You have to know this law if you work in this field and you're receiving federal money. 42 CFR would work like this in the scenario that I gave you. So 5 Violent Crimes Division officers show up at your door and they're demanding to see a client in connection to a murder case. And they're saying, we know that person's here and we need you to give us access to him. Your response needs to be, I can't confirm or deny that person is here. Now it goes beyond that though, because law enforcement can obtain information without client consent. What they need to do though, is they need to get a court order, very specific court order signed by a judge. That court order has to be in relation to a serious crime, like rape, murder, armed robbery, something of that nature. And there has to be no other way that law enforcement could obtain this information other than coming to your agency. That has to be there. The court order has to contain those things and some other elements that you can read about if you go to that the electronic version of that law. The other thing they need is a subpoena. They need both things in order to get information from you or from the client. They need to have that court order and they need to have a subpoena, both things. The court order would allow you to give information to law enforcement, but it doesn't compel you to. The subpoena compels you to. You have to have both things to be compelled to release information. Many people think a court order by itself or a subpoena by itself are sufficient, and they're not. Search warrants are not sufficient. It also doesn't matter if the police know that the person's there. That doesn't factor into it. You still can't confirm or deny the person's there. If the police leave in this scenario, they go to the judge to get the proper court order and they get a proper subpoena and they bring it back to you and they have a photo ID of the client to prove that this is the person they're there to question. If all of those things take place, then you can give them access to the client. When releasing records, that is if the police didn't show up at your door but they're requesting records on someone, the same process has to be followed if the client won't sign a consent form. But you only provide the information necessary. That pretty much goes for any request for information. Only the information necessary to meet the need after the proper documents have been received. So ethical dilemmas along these lines. I'm going to talk a little bit more about 42 CFR Part 2. But the ethical dilemmas that can come into play with clinicians is, if this person's wanted for murder, or we think they are, shouldn't I tell the police that they're here for the good of the rest of the people in our facility? Shouldn't I take some action here, regardless of whether there's the proper documents or there's a consent in place? Shouldn't I do what's in the best interest of all the clients here? That's the kind of thing that can pop up as a result of this particular scenario. And you have to be prepared to respond to it. And just to give you so you have some frame of reference here, the way I would respond to that is to say, we don't know if this person murdered anybody. We don't know anything beyond they want to question this person. So therefore, I would follow the strict privacy laws, and just if you felt like you needed to take some preventive measures to make sure your staff and other clients are safe, just monitoring things a little more closely maybe. But that's how you need to respond to a law enforcement request for information. Now, 42 CFR is a law that basically says you can't release any information to anyone without a client's written consent. The consent form has to, again, have certain elements in it. Now, there are always exceptions. There has to be exceptions to every law practically. One exception is in the case of a medical emergency. If a client is having a seizure, heart attack, whatever the case may be, you can call 911. You have to call 911 and report that and give them whatever information they need to treat the client. Another exception would be if the client commits a crime on your premises, if they assault somebody, if they throw a TV on the floor and smash it, something of that nature, then you can report them to law enforcement without their consent. You can also report child abuse, person's consent. The only other way, I take that back, the other way that I've just talked about is through a court order and a subpoena. There's one other method that allows agencies to talk to each other without client consent. It's called a Qualified Service Organization Agreement, or QSOA. Those are agreements, you think of them in terms of being similar to a HIPAA business agreement. Those are agreements between organizations where the substance abuse treatment provider has this agreement signed with another organization that provides services that the substance abuse treatment provider doesn't have. So if you partnered with another organization, say they do case management or something of that nature, and that's something that would benefit your clients coming out of substance abuse treatment, you can form one of these agreements between the organizations so that you communicate some client information without that client's consent, because it's really, that other program is viewed as an extension of your own program. And by virtue of that, that other program is held to the same confidentiality requirements that any substance abuse treatment provider is held to, 42 CFR Part 2. It's a really important law, and you have to know it. It was passed in 1973, I believe. It's more restrictive than HIPAA. It's more restrictive than any other privacy law. And it needs to be understood so that you don't accidentally violate it and put your license in jeopardy or your certification in jeopardy, and or cause your organization to be fined. The fines are progressive. They're not huge, but that's really not the point. Your license could be in jeopardy if you violate this law. So, that's the answer. I just talked about this. You can Google 42 CFR Part 2, and an electronic version of that law will come up, and you can look at the different sections of it electronically. So you can find it very easily by just Googling it. HIPAA is the other privacy law. It stands for Health Insurance Portability and Accountability Act, which was also passed to provide some protection for patient data when agencies are exchanging data. But it's less restrictive, as I've said, than the federal law for substance abuse treatment programs. So you want to be careful that you're not just following HIPAA law. You always use the more restrictive law. If your state, so in any case, whether it's a state or federal confidentiality law, you go with the one that's more restrictive if there are different variations in it. All right, so I just put this in here. I think it's a fairly, I won't say easy, but it's a fairly common sort of ethical dilemma. A drug counselor is contacted by a client's medical doctor who is interested in obtaining information about the client's progress. The client is given permission to release information. The counselor should. And I won't hold you in suspense. I'll give you a chance to read them, though. And the answer is the doctor only the information that is requested. Remember that a release of information doesn't mean you have to give information. It means you're allowed to. So if a client signs a consent form to someone, say a probation officer or even a family member, and you believe it's not in the client's best interest to reveal certain information, it's your right to do that. All the consent form does is it gives you permission to discuss certain things with certain people. Always make sure those consent forms are filled out completely, or oftentimes they're not valid. I think these are things we sort of covered in a roundabout way, but policies and management really set the stage for ethical decision making. A policy or your agency's management team can't rule out every potential scenario that you might face for making ethical decisions, but they can establish a spirit of how to manage those situations, or generalized explanation for, or I should say definition of how that agency wants to respond to people in their programs. And those policies and that management leadership really sets the stage for how people are going to respond in any given situation. Always report unethical behavior, and always make sure you understand the ethical guidelines that your organization and or your license require. It's oftentimes it's most of the time, it's an inadvertent violation. You do something because you thought it was the best thing to do for the client. That can result in problems with violations of the federal confidentiality law, and it can sometimes result in other ethical violations. Most all of us who work in this field, our intentions are good, but we really have to pay attention to not just our intentions, but does this fit within the guidelines of ethical standards and law, quite honestly. Competence, of course, involves ongoing education, but go beyond the mandatory CEUs that you might have to get to keep your license current. Really explore, as I said before, really explore current theory and current science behind addiction and mental health disorders. Understand the whole person perspective and how addiction is a part of the overall health of a person. If we only treat the addiction, that is, if we only focus on that, we're missing a tremendous amount of opportunity to help that person change other areas of their life that are contributing to their addiction. We have to step back a little bit, recognize our own scope of practice and our expertise, and recognize those who have other people who have expertise in different areas, and communicate with them, work with them as best we can. Whole person care, longitudinal care, health home models, and ecological models of care are all things that are going to be more and more familiar if they're not already familiar to you. This is the direction the field's going. It's going in the direction of integration and coordination of care, and I think that's a really good thing. The last point about that I would make is we really need a primary care presence in addictions treatment. We need doctors, we need nurse practitioners, and we need physician's assistants to be a part of what we do. This is a very complicated illness. The people who have the disease of addiction and have co-occurring disorders require very complex treatment plans and a multidimensional approach to helping them. The days of the 30, or in the past, the 30-day treatment stay, that's been the standard for so long. It's really an ineffective model to follow. Really, for brain changes to occur, that is, for the brain to stabilize a bit and return to more normal functioning, from alcohol specifically, it can take 4 or 5 months before that person's brain is functioning properly, before they have executive functioning skills that to a level that they had prior to their addiction, and for craving to diminish. What we've been doing, I don't mean to go off on a tangent here, but what we've been doing as a profession is keeping people for 30 days and releasing them with the expectation that they do well. When in reality, even though that person might look and talk and behave as though they understand what they need to do, that they're fully competent at that point to make decisions for themselves. The reality is that their brains have been affected to the point where executive functioning skills are diminished by sometimes up to 60%. That is, they have the inability to make good decisions, to think logically, and to problem solve. Combine that with an increased or very heightened craving in the limbic system, and you have a recipe for relapse. You have people who still have the inability to make good decisions combined with a high potential for relapse due to craving. So the idea is to treat the person for the length of time necessary to allow them their brains to heal, and for an opportunity to make sure that the proper dosage of care is being provided, and we're not just cutting them off after 30 days. I mean, imagine going in for some other treatment for some other disease, asthma or diabetes, and after 30 days the physician says, well, you should be able to manage this on your own, so don't come back. Or they say, if you don't comply with the diet or regimen of medications, then we won't treat you. It's backwards thinking, and we need to move in a direction of progressive thinking to include other professions, other ways of thinking about this disease. So these are some definitions of ethical principles. I'm not going to read them out loud. I think you all can read, so it's always a pet peeve of mine when presenters read the slides anyway. But there's a link at the bottom there that you can click on if you want more information. Just one point though, and this doesn't really connect directly with this bullet point, but fidelity is an issue with treatment programs in general, where we need to, as a profession, provide an approach, have a particular approach to addictions that's common, at least at the foundation, so that we can talk to each other in the same language, so that we're treating people effectively across the board. And I'm sorry to use the analogy all the time with primary care, but if you go to a doctor in California or you go to a doctor in Maine, you're going to get a similar treatment for whatever the disease is that you're consulting about. And we really need as a field to get to that place where we can talk to each other with a common language and provide a service that has some foundational elements that are the same across the board. It was more of an editorial than anything. Boundary setting, do no harm. Transference and countertransference are things you probably have heard a lot about. It's something really to pay attention to. Countertransference, especially, well, I won't say especially. Transference is an important topic, something as we self-monitor, something that we need to always be aware of. Do no harm. Personally, as a professional, I think it's best if we never have a sexual relationship with a client, former client. I know there are codes of ethics that say after 2 years you can have a relationship with a former client. My opinion of that is it's never a good idea. There's always that power differential. If that client knew you as a professional at one point, they're always going to see you a little differently than they would otherwise. So I think there's always the potential there for that power differential to have a negative effect on the person who was the client. So my take on that is just don't do it. And don't act on feelings, certainly. Don't respond to affectionate kinds of behavior on the part of the client. I think these things are pretty common sense. So we talked about duty to warn, child abuse, sexual misconduct of the therapist. This is mandatory reporting for ethical violations. Well, I guess it's also mandatory reporting in case of duty to warn if there's a specific threat or child abuse. Clinicians who use their supervisors to think through situations, to get advice, to bounce ideas off of them, much, I think, better prepared, much, well, I should say their skills are more advanced than those who don't do that sort of thing. Any clinician, regardless of how good you are or how much you know, should use clinical supervision as an opportunity to fine-tune and hone your skills with the goal being of providing better client care. It really makes your job, I think, more interesting. It's an intellectual sometimes discussion with your clinical supervisor that can trigger new thoughts or open new doors for you to explore. Certainly, I would recommend that. I think it's necessary if you truly want to be an effective clinician. All right, so I realize it's only 12:50, but I was leaving a little time at the end of this training to answer some questions you might have. I was thinking there might be some around 42 CFR Part 2, or if you just had questions or comments about anything I've said, and also to just provide any clarification if I need to do that. But the key points to remember from the presentation are be good, do good, and above all, do no harm. You always want to do what's in the best interest of the client. Ethically, that gets difficult, just to recap, is when the thing that you think is in the best interest of the client violates a law or violates an ethical code. That's where I think most ethical conflicts come into play. It's when you're trying to do what's best for the client, but something else, a law or a code of ethics, doesn't seem to quite fit the situation or prevents you from doing the thing that you think is best for the client. An example of that, for instance, would be if a concerned mother and father were contacting you and saying, you know, we dropped our son off at your facility yesterday, and we just want to know how he's doing. We want to make sure he's, you know, we're supporting him. We want to help in his recovery. We want to just be there for him. And the son refused to sign a consent form, and you're not allowed to speak with the parents. You're not even allowed to acknowledge that person, that their son is in treatment. And I've seen this happen where clinicians will kind of on the side say to the parents or say to someone like a family member, well, you know, I'm not supposed to talk about this, but just so you know, your son's doing fine, but, you know, don't ever do that. It's an easy trap to fall into, and I realize that the intention is good. when you do that sort of thing, if that client found out about it and wanted to pursue it, you could license it, put in certification jeopardy, and cause all kinds of problems for your agency. So we really have to respect the wishes of the client, even though we believe something would be in their best interest. They don't want any part of it. The client gets to make that. Boundary issues are, I would hope that if you're watching this webinar, that you've enough discussion around understand boundaries. We'll give you take questions. I will give you one example where boundary issues and confidentiality are problematic, and that's I worked in Hawaii for a while, and obviously I worked on an island where most everybody knew everybody. So as a clinician, there was no way really that you could treat people that you didn't know. So those boundaries were very difficult to establish because the clinicians oftentimes had lifelong connections with families or the person that was in treatment, and there really was nowhere else for that person to go, right? So it set up a unique dynamic, and I know some Native American communities face this same challenge. How do you provide a service to someone in a objective way, or how do you avoid treating somebody close to you if there's no other option available, and if that kind of scenario is common? And it's a very interesting discussion, and I don't have the answer to that. I think our solution to it in Hawaii was to really do the best we could with the counselors we had, and find the person that was least likely to have some sort of personal connection to the client. But it was really a challenge, and one that, as I've said, Native American communities face all the time too. And again, you have to go back to your clinical supervisor, your organization's policies, and comply with the ethical standards as best you can under those circumstances. But I'm going to be quiet now, and if you have some questions, be happy to answer them.
Great, thanks, Bob. Looks like we do have one question here from Cindy. She's asking, are there examples of qualified service agreements that we could review?
Yes, actually, if you Google Qualified Service Organization Agreement, you'll get some templates. Those templates are pretty accurate. You'd want your lawyer to look at them. But they're a one-page document, and in spite of everything I've said about this law being so comprehensive and restrictive, these documents are actually quite simple. But the specific language that your organization would need to consider are in those templates. Again, have your lawyers look at them and compare them with what's discussed in 42 CFR Part 2 to make sure they comply with the law. But they're pretty easy to find. I know when I was looking into this, I just Googled it until I found a legitimate source, for the document, and then I took it to our attorney and hashed through it with him.
Great, thanks. I noticed some people might have been trying the option to raise your hand. Unfortunately, because that will try to connect your audio to ask a question. We don't use that feature, so please, if you have questions, type them into the Q&A pod, and we will see them and respond to them that way. Then we have another question from Charlene. We also serve inmates at the tribal jail. There's not often confidential space from primarily jail staff there to collect evaluation information to get them into inpatient treatment. What cautions or boundaries do you recommend?
Well, this is one of those difficult situations. I used to do assessments in jails, but I was provided with a private room. If you're not, you have to sometimes take the situation you're in and make the best of it. I don't think anybody's going to fault you if you're in a position where you have to deal with um, less than ideal circumstances. Do your best to keep the conversation private. Do your best to ensure the individual that your intention is not to make this a public spectacle, that you're trying to be quiet and confidential, and that you're um, both faced with this difficult situation. You know, again, I don't want to tell you how to deal with that. I think it would be a discussion with jail and with supervisors as to how to improve that, so that you're not faced with that every time you try an assessment. Did I answer that properly? So.
And let us know if you have any follow-up questions on that. No more. Oh, we just got another question from Anne. How do you address boundary issues between staff?
That's a great question. Was that the end of the question? Okay.
Yes.
That's a great question. In fact, I would say that's more common than boundary issues with clients. It goes back to leadership, essentially. It goes back to the expectation for employees that you have as an organization. And you say things like, when you see those boundary issues, and they could be a variety of things. It could be boundary issues between two different professions. It could be employees that are colluding to do something that's not quite the best interest of the agency or the client. I would say the short answer is, if you see something going on that's some sort of boundary issue between employees, you have to address it right away and stop it, whatever it is. If it's problematic, or even if you become aware of something and you're not sure if it's true, at least bring it up with the employee and say, this is what I'm hearing this. I don't know if it's true, but let's make sure we're on the same page with the policy and what we expect of you. Those kinds of things, if they're left alone, they often don't heal themselves, and they turn into something much bigger. The problem never seldom goes away. So you really just have to address the issue however you would as a leader or supervisor, or just a colleague. Bring it to your supervisor's attention, I guess, if you're a colleague.
Wonderful. Then we have another question from Cindy. Working with individuals who have guardians gets complicated and not always sure about this.
Yeah, it is complicated. Yeah. A guardian, my understanding of a guardian is that they have the power to petition for services instead of the client, or on behalf of the client, I mean. So the guardian has is the person essentially petitioning for services on behalf of the client. Let me think how to explain that more clearly. Say a client came to my facility and was here for admission, and the client says, I don't want to be here. I don't want to be admitted. But the person has a guardian who legally can make that decision for them. So the guardian is saying, yes, I'm asking for this person to be admitted. The guardian has the authority to do that. I can't think of another word right now, but petition for services. But it gets complicated, I know, and beyond that, I hate to go into too much detail because I'll probably be wrong.
Okay, well, looks like that's all the questions that we have at the moment. Bob, did you want to go back at all and look at people's responses to that that issue that you brought up at the beginning of the webinar?
Yeah, I think most people had the right idea. I think where I'm seeing a theme is that most people said we can't give any information without a signed consent form. but what I'm seeing is that a lot of people didn't know the alternative to that. That is, what do you offer the officers as an alternative? Do you just say, I can't provide you any information, period, and that's the end of it? You have to, in this case, you have to make them aware of the process that they would need to follow in order to get the information they want. So just, again, either contacting your attorney or making them aware of the law itself and saying, here's the process you have to follow before I can give you any information about anyone here. So that would be the, I think, the overall theme when I read through this, that people are saying, which is good, they're saying, I'm not going to give you any information, but we have to follow up with, here's how you could obtain it, and this is the only way you could obtain it. There is one thing I left out of that discussion that's important. If the person is not in your facility, if the police or anyone else calls you and they say, we desperately need to talk to so-and-so, we know they're in your, or we think they're in your facility. If the person is not there, if they're not in your care, you can tell them that. You can say, this person is not in our facility. Now, you can't give them any other information. You can't say, but they were here yesterday, and so you want to be careful. You can tell them that because it prevents law enforcement or someone else from going through all those steps to obtain information when the person was never there to begin with. It's a poor use of law enforcement time, especially if they're really needing to get a hold of somebody. So what that does is it's not acknowledging one way or the other whether that person's ever been there. It's just acknowledging the fact that at that moment they're not in your facility. So that's okay to do.
Great. Looks like we have another couple of questions yet. From Emma, she asks, if you are having a session with a client and they ask that a person be present during that session, do we have to have a release for them? Or is by word of mouth good and you just document that they have asked that the person be in the session?
It has to be a signed written consent, and it has to comply with what the consent is required to contain in it, which is listed in 42 CFR Part 2. They actually have examples of consent forms on the website. So you have to have written permission from the client, signed by the client.
Great. Another question from Lisa. I just attended a training where the presenter said that if the law is involved, we can give law enforcement the information. I thought this was wrong from my previous years of experience.
You're right. It's wrong. You can't. They don't have any special privilege. In fact, the law was developed primarily to protect people from law enforcement. Reason being, 1973, they thought if law enforcement had access to our clients, then none of our clients would come to treatment, which is probably true. So the law was developed with the intention of making it very difficult for law enforcement to gain access to our clients. You cannot give them information without a consent or without them presenting you with a proper court order and a subpoena, both things.
Great. Well, great questions, and thank you everyone for participating. If you have any other questions, please submit them now. It looks like we're getting close to what might be the end, and unless we have more, please submit those, and I'll just go through a few final instructions here, and then come back in case we have any other questions to address. Just so you know, we will be sending an email follow-up to everyone who attended. It will include a link to the recording of this webinar. So if you wanted to pass this on to anyone who may not have been able to attend, or if you want to view it again for yourself, that will be included in the email. We'll also include a link to the survey. I know some people have had trouble accessing it when we close out the webinar, so the link to the survey will be in the email, and also the CEH request form and handouts of this presentation. And coming up next in this series is, of course, the clinical evaluation screening. That's going to be presented by Dr. Peter Nathan on November 19th. And a really great session we're looking forward to on November 5th for our American Indian and Alaska Native Behavioral Health Series, Creative Moving Stories Play Therapy Method. So we'd love to have everyone join us for that. Let's see, looks like we've got a few more questions, so we'll take those at this time. All right. From Jackie, what about an impaired client who leaves clinic and drives under the influence? Is that not reportable as it is a danger to self and others?
You can report it anonymously. You can call the sheriff's department and just make an anonymous report of a vehicle with that license plate, but you can't identify yourself as a employee of a treatment program or identify the client or the person as a client of yours. It'd have to be an anonymous call. I think for public safety, it would be a good idea to do that, though.
Okay. And Anne has a follow-up to Emma's question, which let me go back to that one a minute. This is where she was talking about having a session with the client and they ask that a person be present. And Bobby confirmed that a release would have to be signed by the client in order for that to happen. So Anna is asking, does this include family sessions? Would the client need to have a signed release for this if they are in inpatient treatment?
Yes. Yep. Now, I want to be clear though. Yes, you would need to have a signed consent to give any information to anyone. If a family member called you, wanted to give you information, even though you couldn't confirm or deny their family member was a client of yours, you can listen to anything they want to tell you. You can't say whether the person's there or not, but you can say, if there's anything you'd like to tell me, feel free. And then you can gather as much information as you want, but you just can't reveal anything. Now, if a client wants their family involved in their treatment, they're more than likely going to sign a consent form. I'm sorry, can I make one other comment? I don't want to make this too confusing. Along the lines of law enforcement again. If law enforcement shows up and they want to have access to a client and you can't tell them anything, you can say, I don't know if that person's here or not. If you wait a minute, I'll go see they are here and they sign a consent form, I can talk to you. So you go back, you ask the client, would you like to sign a consent form so we can talk to the police? They're here to pick you up on a warrant. Do you want to just deal with this now? And if the client says, yeah, I'll just deal with it now and sign a consent form, then you can talk to the police. If the client says, no, don't tell them I'm here. That's what you have to do. You go back out and you say, I'm sorry, I can't confirm or deny that person's here. So hope that made sense.
Wonderful. Well, it looks like that is all the questions that we have for now. Well, looks like another one just came in. All right. For Michelle, when I took my certification tests, one of the questions was, if you work in a treatment facility and you see a client steal a television from the treatment center and you are watching him put it in the backseat of his car, what do you do? The choices were contact a supervisor, call police, chase him and take it back, and can't remember the last option. What is the answer to this question, and how do you report this crime without disclosing that they are a patient? She says she has no idea if she got this wrong or right at the time.
Well, I don't know what the right answer was, but my answer would be to tell your supervisor, and yes, you can give the clients information. If they commit a crime on the premises of your facility, you can report them. You can give information about them without their consent if it's a crime committed on the premises. But if I were you and I saw somebody do that, my answer would be, I'd tell my supervisor about it. And your supervisor can tell you, yes, go ahead and call the police. But you can report it if it's a crime on the premises. Can I always have these follow-up answers. I'm sorry, but it's sort of a large topic. if someone comes in to your agency and they tell you they've committed a crime like murder or rape or something in the past, you cannot report that. Only if they commit a crime on your premises. You can't tell law enforcement, so-and-so was here, they said they murdered somebody last year. You can't do it under the law. Even if ethically it seems like the right thing, you can't.
Okay. Well, thank you so much, Bob, for your this presentation today and bringing your experience. It's been really valuable, and all of the anecdotes and stories are really helpful to sort of bring all these ethical questions to light. So thank you so much for presenting this information to us today. And I want to thank everyone for participating and all the great questions. This has been a really wonderful session, and just thank you so much for being a part of it. And Bob, did you have anything final you wanted to say before we close out?
No, just thank you. Thank you all for participating.
Wonderful. And thanks again. And while I close out here, hopefully you'll be redirected to our survey. And like I said, if not, you should be receiving an email within the next 24 hours with that information. And thanks again. Have a great day.